right, so we're here today with Dr. Mike Sumko from the Arizona Sports Medicine Center. Um, Dr. Sumko is uh, a great guy who's been wonderful enough to give us some of his time. He's a busy man, but we really appreciate him coming on here and providing for our staff and for our patients as well some insight into the life and the world of what an orthopedic surgeon does and how we can work together to be better. So, hey, thank you, Dr. Sumko. Really appreciate you spending some
Yeah,
time with us.
no, thank you for having me. No, my pleasure. I appreciate the opportunity to be able to share whatever knowledge or whatever I can with you. And I appreciate you taking the time to interview me and find out a little bit more about how we can work together and any of the new insights on orthopedics and total joints and I think it's always great when you have the opportunity to talk to therapists or talk to the community and knowledge is power. So thanks for having me. It's my pleasure.
You bet, you bet. I've been doing this for 25 years, and so I'm kind of a dinosaur now. But I know I'm going to learn some things that are going to be helpful. But let's start off. Tell us a little bit about your background and how you got into orthopedic surgery.
Yeah, you bet. So I am my father's an orthopedic surgeon.
Okay.
So I actually grew up in a smaller town. I'm a military brat. He went through the military for his training. Got out of the military, moved to a little small town in Utah, Brigham City, Utah. And he was one of two orthopedic surgeons in the town. He had one other partner. And so I grew up going to house calls.
Wow.
We'd be in town and he'd get a phone call and we'd go stop by someone's house. And, the few times I say fortunate I was able to go, I learned a lot and I started to realize the appreciation that people in my town had for my father. And being a small town of about 13,000 people, they knew who you were. So I always had to behave. And at the same time, though, it was nice to hear from people throughout growing up in high school and around the town, just tell me how much they appreciated the things that my father did for them. And so it really made me think that, hey, this is a gratifying profession. I wanted to be able to help people. And I saw it firsthand by my dad being such a good example and a good surgeon and a people person. And so that's kind of what gravitated and focused me towards orthopedics and the medical field. And then through college, I investigated dentistry versus medicine and ended up deciding to do orthopedics. I love working with my hands. Did my residency out east training, came back to Arizona for fellowship in total joints, hip and knee replacement, and less invasive approaches. So I did that extra year beyond the 4 years of med school, 5 years orthopedic residency, and then a year fellowship
Oh,
and in minimally invasive joints. And that's what I do. I do outpatient, total hip and total knee replacements, and they're less invasive and been very fortunate and been able to build something, a really good team that I'm surrounded by and get to know therapists like yourself and more therapy in the community that have just been very helpful in helping us to have success. And so that's kind of
okay.
it. I love orthopedics. I love working with my hands. Um,
You,
I,
you're
that's
telling me this story, as you're telling this story, something like this strong memory comes to my mind. So I grew up in working as a young man for my father, who had his own business, and it was also in hospitals. But it was like 4 or 5 hospitals all around the Phoenix area. And what we did was painted walls and fixed drywall and carpet and that kind of thing. So I was like in the construction industry with my dad. And I remember something you said there sparked a thought. I remember it here over the loudspeaker, they're calling Dr. So-and-so, Dr. So-and-so, please report or whatever. I remember thinking, man, that would be so neat if I could be a doctor someday. You know what I mean? It was just so exciting, the idea. And so when I saw, you know, the sports medicine side, because I was into sports and stuff, uh, and I saw physical therapy, and I thought, well, it's not a doctor. Really, now a lot of people graduated with doctorate degrees, but it wasn't at the time. But it's still like to me, it was part of my decision is just being in a hospital and realizing wow, these people are really relied upon to do things. And anyway, so I just share that memory because it sparks it in my thought, but little different angle. But that's neat that you were able to be with your dad. Has your dad ever joined you in the surgical suite while you're doing?
So yeah, so really cool. So I'm an orthopedic surgeon. My other brother is also an orthopedic surgeon, and
Wow.
my other brother is a medical device rep, and for orthopedics. So we
Wow.
kind of got involved and stuck around it. And yeah, very cool is when during medical school, your first year out, you get to go for summer. You get to go home for summer. So I got to go home and get privileges and scrub in and assist him, which was really neat, and do some research.
Hmm.
And then later on, once I was an orthopedic surgeon, he got to come down. And as I started to do these less invasive techniques and have extra training, he came down and learned how to do the muscle sparing approaches with me, and then went back and applied it to his practice, his last 3 years of practicing. And when he retired, he came down and I did his total knee. And so I actually, yeah, I
That's so
probably
cool.
did the cardinal sin of operating on a family member. And I really didn't want to.
Oh,
But he had scrubbed with me and he said, "Hey, I've been around a lot of surgeons. I know how particular you are. I've scrubbed with you. I really feel comfortable with you doing it." And yeah, it was a little bit of pressure for me, obviously being my father.
right.
But obviously it went very well. He's super, super happy. We share that connection, and the jealousy of my brother, my younger brother, who didn't get to do his dad's knee. But I told him he could do the revision if he needed it.
Yeah, but
So,
into
so
the
my brother can do the
complicated.
harder case if need be. But
Love it.
so it's been a full circle for us, and just been awesome to have a dad where I've been able to shoot things back and forth, and
That's
he's not
cool.
just fatherly advice, but orthopedic stuff. And so, yeah, it's been quite the whirlwind. But yeah, I do appreciate everything I've learned, and I obviously learned a lot from him.
That's neat. That's really neat. You're talking about your your experience of all these years of training and an additional year, like not like an additional month, it's an additional
Yeah,
year. Like
yeah,
in these terms, it's amazing to me. Like it blows my mind. Like, okay, it was an additional year, additional 5 years, That's a lot of time that is put in to be able to do something like this. And they don't just hand out fellowships to orthopedic surgeons either. I mean, it's always been said to me like the orthopedic surgery or fellowships are the most competitive and difficult to get, right? I
yeah.
don't know if that's true or if that's just something I've heard, but because a lot of people would like to do that work. And so, congratulations to you, and wow, what a whole family of people who have risen to the top of not just becoming a doctor, but becoming orthopedic surgeons. That's really impressive.
Well, thank you. No, we very blessed. We feel blessed, and it's nice to have that influence, early on, and kind of help direct you and kind of steer. And really, I kind of say I was probably just not versed in any business or anything else. I just was not ever exposed to it. So I had no other thing to know or idea to go. I might have chosen otherwise, but no.
So tell me, Kay, you told us that you're primarily doing these muscle sparing, procedures. Tell us a little bit more about those, if you would.
Sure. Yeah. So I did my orthopedic residency. I really like total joints. I like working with saws, hammers. I like, I'd be a car mechanic if I wasn't orthopedic, I think.
Drills.
And yeah, drills and tools, or a carpenter. And I decided I wanted to do a fellowship because I wanted to learn less invasive approaches and really hone in my skills. And, I think that was good advice from my dad. He said, you can be a generalist, and you can be, really good at, you can be decent at a lot of things, or you can be specialized and be really good at a few things. And for me, the way my mind works, I really like to try and be as good as I can be at a few things. And so I decided to do the fellowship. I did it here in Phoenix with Tony Headley, who's passed away since now, but was an amazing surgeon, amazing mentor, and fantastic with teaching, protecting the tissues and the soft tissues. And, his big thing is he said, "Hey, a total joint's a soft tissue technique. It's the ligaments, it's the tendons, it's balancing. The cartilage, it's not so much a cartilage technique, although that's what wears out when our ACL wears out, or when we've had an injury to ligaments. Basically, the structure changes, and that's when you damage the cartilage. And once the cartilage is damaged, you need to replace that with artificial prosthetics, but you also need to balance the ligaments, and you need to protect the tissues. And when you do that, that's where you have the best results the most quickly. And so it's a soft tissue technique. And so I really focus my practice on muscle sparing, soft tissue techniques, less invasive and outpatient total joints. And that's what I've come to love and do. And I'll send 100% of my patients home same day. And since COVID, I didn't start doing that until actually COVID came and they shut the hospitals down. And I had a waiting list of people who've been waiting several months for their joints. And I thought, this isn't fair to tell them, hey, I don't know when I'm going to get to you.
Yeah.
And we couldn't admit people into the hospital because we had to keep those beds open for sick people. And that's when I said, you know what, I'm just going to send them home from the PACU. I've been sending them home the next morning for the last 7 years or 8 years of my career. I'm just going to send them home. And so I started doing it, and people loved it. And it's been awesome. And I, have tried to be very innovative in my preoperative optimization of patients. And I've been able to incorporate some things, some cryotherapy and stuff like that. And I'm now about 85%, almost 90% of my patients never take a single narcotic.
No
And
kidding.
I think that's becoming revolutionary in my practice, which I would love to not prescribe any narcotics. And I
Yeah.
probably could do it, or I could do a step down uh, pain pill that's not a non-narcotic tramadol, which is a opioid synthetic. I could do that, and I know I could do that fine from right now. But I would love just to be able to prescribe my aspirin and Tylenol and my anti-inflammatory, which basically 90% of my patients just do that regimen.
Wow, that's amazing. That's new from my experience. I haven't known. I know that there's definitely a lot of research in pain that is physical therapists that we're learning to work with people to get them away from the use of opioids because, they're
Yeah,
accustomed to asking for them and in some cases, getting them. And so it's sort of like hey, I have to have this. And so we have there's some really great research and some training that we are taking as physical therapists on helping people be able to grasp and understand what pain is and with that understanding reduce the need for these things. And so that's awesome that you're getting that kind of percentage of people without narcotics. That's incredible.
thank
Awesome.
you.
I'm
Thank
really
you.
glad to pass that along to my people as well. So,
I
um,
appreciate it. It's been awesome. The way I'm able to do that is, first of all, trying to optimize patients. It's getting them to make sure their diabetes is controlled, they're not smoking, trying to optimize their weight and their BMI, things that help reduce the forces and allow the medicines to be more efficient or effective after surgery. And then with the total knees, it's cryotherapy, IOVER. My PA does that under ultrasound guidance. He's very well trained. Not a lot of guys do that in the Valley. And that's because when it first came out, first of all, insurances weren't recognizing it and it wasn't affordable. It didn't make sense in the clinic. You were actually making no money, if not losing money, with dedicating time to doing the procedure. Things got a little bit better. They started to involve a longer needle. So if you're ultrasound guided trained, you could actually see the nerve and then inject the nerve versus the traditional technique, which 95% of people probably do, where they measure it out and they just start making all these little poke holes and injections, hoping to get close to the nerve. But we started that way, and we didn't get the results that we wanted. And then once we started doing it with ultrasound guidance, and even more so with the longer needle, that's when we started to have real results, and patients started to clinically our outcomes were significantly improved and better. And I've just made that part of my practice. And that's also been part of helping you freeze the nerves. Basically what you do, the 5 sensory nerves around the knees, you locate them, you freeze them 2 weeks before the procedure. What that does is it causes the nerve sheath to kind of go away. It freezes them. Ablation is the burning of the nerve sheath away. cryotherapy is the freezing or the shrinking of the sheath so that it doesn't transmit the signal. And so people don't feel the pain as much. And that's what allows them to move their knee a little more aggressively in therapy afterwards. And that nerve grows back, usually about 2 months of relief, sensory wise. And so that's kind of been a really cool thing to add to my practice. And once again, not a lot of people do it here in the Valley, and that's because either their PAs or themselves are not ultrasound guided trained. They're not using the longer needle. And they've tried the old technique, and the old technique just doesn't quite do what it was originally supposed to do. But the way we've done it, and I just have such an awesome PA, Drew, who's phenomenal and very good with his hands and very good with ultrasound, been doing it for over 10 years. Has picked up this Iovera, and he's probably one of the top leading guys, out here in the state, if not the West, and being able to do these procedures and do them successfully.
Wow. And does he provide that for a lot of the surgeons in your practice, or
So
just?
some surgeons will send us patients, and some people not in our practice. Some surgeons in the Valley will send us patients who read about it and really want it. And so we're happy to always provide it for anybody.
Hmm.
As long as it doesn't take him away from from his own responsibilities. But yeah, so we do that occasionally for some other surgeons. Yes.
Okay. Wow. That's awesome. And that is something I didn't know about. That was a perfect segue, because I was just going to ask you, what are some of the exciting technologies and changes that you're seeing right now? That's got to be one of the biggest ones right there in pain
Yeah.
modulation. And are there others that come to mind that are soon to come, or that are uh,
Um,
recently emerged?
I think that's probably so yeah, that's probably one of the newer things, the cryotherapy within the last 5 years. And we've been doing it now. We tried to do it when it initially first came out, but we've probably been doing it for 4 years now. So we also have a long track record of being able to not only do it, but to follow our patients clinically. Um, so that's great in the pre-optimization. We even do that too for people who are non-operative candidates who are struggling with injections that aren't helping them. So we'll try the cryotherapy, and sometimes that'll give them 3 months or 4 months of decent relief, and you can supplement that with gel injections and steroids. And that's the other thing, Mark, is I'm not just the push towards surgery, but you know what? It's meeting the patient where they're at and trying to find what their goals are and their time frame is, and
Sure.
then providing, utilizing all these things, the cryotherapy, nerve ablation if they fail other things, gel injections, steroid shots. People can do PRP or stem cells, which, those are not covered by insurances, but if people are out there into the rope and they want to do them, I'm happy to try them. I don't push expensive stuff on people. That is tough. Stem cells do great in soft tissue, and cartilage, it's a little bit different. I've seen people go to other practices and spend thousands and thousands of dollars, or, in getting these injections of stem cells when, they don't work great in the knee because the cartilage, it doesn't renew or regrow the cartilage like people think that it will.
Yeah.
Um, and unfortunately, fortunately, it has good anti-inflammatory properties, and it helps a little, but it doesn't regrow the cartilage. And it's hard for me to say, hey, spend a couple $1,000 here to have 3 months of relief and have it be no different than a steroid shot or gel
Yeah.
injections. But it's there if people want to really do it, and we failed other exhaustive measures and they can't have surgery for whatever reason. I have done stem cells before for some very old patients who are not cleared to have surgery.
And with gel injections, is there any changes? Is it still like some of the hyaluronic acid?
Yeah, it's the hyaluronic acid. Lots of different companies. There's more companies that have come up in the past few years, so you can do a series of just one shot, or a series of three, or a series of five. Different companies. They're all pretty much the same. It's a high molecular weight, viscous protein that you inject into the knee. It helps lubricate the surfaces, and so for any therapists or people understanding, the big difference between that and steroid shots is the steroid shot directly goes in as an anti-inflammatory and helps decrease the inflammation, helps reduce the pain pretty instantly. The gels go in and they help lubricate the surface and decrease the pressure and help prevent the inflammation. So you got one that fights inflammation instantly, you got one that prevents it. So the combination of the two sometimes, or alternating them, for people who don't want knee surgery, is a good way of doing conservative treatment.
Yeah. Okay, good. I've wondered that because, you know, that's those different injections have been done for years and years on all kinds of things, rooster comb and shark cartilage and,
Yeah, yeah.
all these now artificially created things. And I just wondered how much of that is still the same, how much of it's changed. So sounds like a lot of it's not changed in the last several years.
Not too much.
Just
Just different brands that have different molecular weights and
okay.
yeah, so some brands, some people, and I have seen this, people, coming in every 6 months. Insurance approves the gel every 6 months, so you can get one every
Okay.
6 months. Some people say, "Hey, my
Good.
last
No.
one didn't work. Let's try another brand," which I'm happy to
Okay.
try. And if their insurance approves it, we'll get them a different brand. And so some brands work a little better for others and some people. So it's
Interesting.
it's doing whatever we can to help prolong people from having surgery if that's their decision.
Yeah. Yeah. But it's not, oftentimes it's billed as rebuilding your cartilage. That's a fallacy, correct? I mean, this is really lubricating.
Yeah. Yeah, there are a lot of advertising out there and marketing, for different surgical approaches, different injections, different things that can be given. Oh gosh, I can't remember. I had some patient brought me some article recently about, oh, I wish I could remember off the top of my head. It was funny how it was stated, but basically it was hyaluronic acid and they were touting it a different way and they called it like joint juice or something. I can't remember what it
Yeah.
was,
Yeah.
but basically it was a lot of money. And there were injection clinics set up just to do injections where you paid cash. They didn't try and go through your insurance. They
Uh,
just basically kind of sold you something. And unfortunately, people went and paid a lot of money for it. And it was something that basically is more or less the same thing as gel injections. And
temporary help.
yeah, yeah,
Yeah.
temporary help where they could have gone and got it through their insurance.
Yeah. 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 All right. Good. So let's see. What uh, what do you see the role of physical therapy in the treatment of your patients?
So physical therapy is huge. My father was actually a physical therapist before he was an orthopedic surgeon. I don't know if you knew that or not.
Told me that the other day. I'd forgotten though. That's amazing.
Yeah. And and so he always told me, when I was training, I was getting out, he said, listen, um, the people that are most important to you or should be as important to you as anyone else in your surrounding team are your therapists and your nurses. Those are your eyes and ears.
Yeah.
And, therapists, he was in the military. The reason he became an orthopedic surgeon because he was a therapist in the military, and the military surgeons were coming down super hard on him all the time. And he's like, you know what? I don't want to keep getting yelled at, for doing
Hmm.
what I've been trained to do.
Yeah.
And so while he's in the military, there's a path that opened up for him to go to med school and do it. And so he did. And so he said, he said, your therapists are trained in different modalities and they've come from different backgrounds and they do what's in their toolbox and they do the best they can. So allow them to be as good as they can be and
Yeah.
do what they need to for your patients. And so, and respect them. They're in the community. They've seen other people's joints. They know when something isn't right. Give them your cell phone. Let them contact you. Let them reach out to you. It's all about the patient. And so having the eyes and the ears and the therapists out there making sure that your patients are doing well and rehabbing well is super important. It's vital. It's vital to have a successful joint and to be able to get the most out of your joint replacement. So yeah, therapists to me are super important. So I do that. I give my cell phone out and any therapist watching this that don't have it, Mark, you got it, share it with them, or anyone else. And just know it's an open line of communication. And that's something that I'm never bothered by to get a text or a picture. And oftentimes, I'm open even to answering questions about people that aren't my own patient. I don't want to direct care in a different way or whatever, but it's sometimes people say, hey, I'm having a hard time getting a hold of someone. Do I need to be concerned about this? And I'm happy to say yes, or yeah, it's just a second set of eyes and ears. And I appreciate it. And therapists are, really do make the difference for a successful total joint outcome.
Yeah.
And we can do so much here, but there's so much more that has to happen. And that's why therapy is, several weeks, to make that happen. And so, yeah, the relationship is absolutely necessary.
Well, that's so nice to hear because you talk about communication and like I said, I've been doing this for 25 years. And when I first started my practice 22 years ago, um, there was a local orthopedist that was, geographically nearby. We had a good relationship in the fact that he felt comfortable enough for me to help his patients. But there was like no ability to reach out to this person. Like,
Yeah,
uh, and I think I learned early on that you don't bother them. Like you don't bother the surgeons. Like they're busy. They're doing their thing. And if you bother them too much, they'll stop sending you patients. You know what I mean? Type of thing.
yeah,
And so, and I'm sure there's still some people that are like that, right? But it was amazing to me when Dr. Sumko actually came into our office a few years ago and said, "Hey, I want to know who you guys are. I want to know about you. I want to see if maybe you guys are the kind of grade of PTs that I would want to send my people to." And I was like, "Okay, that's never happened before." You know.
well,
So
I had done that because I had had a patient who had rehabbed. I always ask every patient, where are you doing your therapy? Because it's been fun for me to get to know people. But I had one or two people within a course of, I feel like 2 or 3 weeks, that had said that they were doing therapy there and they liked it.
yeah,
They loved it. And they just were raving about who they were doing therapy with. And I said, this is great. I got to go meet these people. Like they're doing really good work for my patients. And so I appreciate that. And
yeah,
so I did want to come out and meet you. And that was from word of mouth directly from patients.
awesome. Well, that's wonderful to hear, and it's great to, yeah, I have your cell phone number, and you've always been responsive anytime I've reached out. So, um, let's see here. Like, w when would you recommend surgery versus more conservative care for your knees and for your hips? Like, what's kind of some guidelines there?
Yeah, that's good. So it's an elective procedure, so it has to be a decision to be made. And some people come in with really bad arthritis, but it doesn't hurt them, and they're still able to do the stuff they love. And so when that's the case, um, I really tell people it's time to get a total joint when a couple things start happening. When you stop losing your range of motion, when you start to lose your range of motion. So when you stop doing the things that you're able to do, um, losing range of motion is tough to get back even after surgery because the ligaments and tendons are tightened down, or you get lots of swelling, chronic swelling. Well, you still tend to have chronic swelling afterwards, and your ligaments are still tight after surgery. So I can do the replacement, but you still got to work through that now. So
Yeah,
when you
yeah,
start to lose range of motion, that's something you got to start thinking about. When you stop doing the things you love, so a total joint should help you be able to play with the grandkids or go to the park or walk or do your activities daily living pretty easily without limitations. When you start planning your days around your knee or your hip.
I like
So
that.
yeah, when people tell me, hey, I go to the grocery store and I know my route and it's down the third aisle, I go to the milk, I then go there and I try and get out as fast as I can. When you start to plan your activities around your hip or your knee, or you stop doing the activities, you stop and people are inviting you to do stuff and you say, you know what, I'm not gonna be able to do that. Sorry, I can't do that. Or I can only hike once a week. I used to hike 3 times a week. If I hike more than once a week, I'm gonna pay the price for the next 3 or 4 days. So those are things, within reason. When I tell people, start thinking about doing a total hip or total knee, because it should help restore your function, your mobility. It should help decrease the pain, and it should help you to be able to do the things you love within normal limitations. You're not supposed to go and run and jump and play professional sports again after total joints, but you should be able to do a lot of things with your total joints: hiking, cycling, pickleball, tennis, all these things that you're able to do, but it shouldn't make
Getting in
it
and
shouldn't
out of
make it.
a
Go ahead.
boat or getting in and out of your truck or
Yeah, exactly. Yeah, the little things. Yeah, people. Yep. And those are often the complaints I hear when they come to see me. I just having problems getting out of my car. You know.
That's helpful because we also filled those questions, right? Because we're working with them on a conservative side, and they're oftentimes going, Yeah, I'm getting better, but I feel like I'm not getting like, I feel like maybe I should consider surgery. How would I know, what I've said for years, in addition to what you said, is um, if this is affecting relationships of people that you love, that and if this is, if that's doing that, that's a reason to take a step, right?
I
Um,
love it. Yeah.
but I like your explanation as well. I'm going to utilize that in our clinics, to help guide people.
Well, yeah, I love that. It's true too with arthritis leads to depression and also pain, right? And so you're absolutely right. It does affect your relationships with people and
Yeah,
even avoiding them, avoiding going to the park with your grandkids or, whatever. But yeah, absolutely. People, when you're in pain, you're just not yourself.
right.
And and the other thing it does, it leads to depression and and isolation and things as you stop doing the stuff you love. And so, and that's the hardest thing, I think, yeah, when people, their activity level changes, when your activity level changes, we don't get any younger. And this, therapists are there to keep us moving. You guys
Yep,
are fantastic after surgery. And even when you don't have surgery and you got an ailment, you help restore the function and the range of motion. You got to keep moving. And when we stop moving, that's when we age.
yep. So good. I love the saying that, I'd rather you wear out than rust out.
Oh, I love
You heard
that.
that before?
I
You
haven't heard.
know? Yeah, it
Yeah, I
needs,
love it.
if you stop moving, rusting out's worse than wearing out.
Yeah. Oh, I love that. That's a good one.
All right. So you have any any patient success stories that come to mind that would be fun to share here?
Oh man, I actually have one that I was going to shoot you the video. I just got it approved by ASMC, so we now have to go through tenant and these, these liabilities that we have with the
Uh,
corporation before they post stuff. But they're going to post a video here pretty soon. A
okay.
lady named Susan, um, probably one of the worst. So as you see, people have a varus thrust where their leg, when they're walking, kind of shifts to the outside. She has a valgus thrust, so she's kind of lost her MCL and she had a horseback riding injury years and years and years ago,
Hmm.
probably a 45-degree valgus when she walks. And
Oh,
when you
gosh.
watch her walk, you just want to almost get
How
sick to
do
your stomach.
you even do
And,
it? Yeah.
and her knee has to, because it bends over so much, it actually has to cross over in front of the other knee when she walks. Has to,
Okay.
cross
Yeah.
over, sorry,
Yeah. Yeah.
behind.
Yeah.
It doesn't work. And so you watch her walk, and when I saw her come in, probably the worst walking I've ever seen. I was just like, I don't even know how you do that. You're wearing out your hip, you're wearing out your back, you're putting all these stresses through your other knee, and just a horrible
Well,
deformed knee. And I ended up doing it, and thank goodness everything went great. She has a straight leg, she walks straight now, and it's very rewarding. I just saw her the other day. She's a year out, and she's like, and she actually touts. I said, well, what advice do you have? And you know what she says? Besides go to Dr. Sumko, do your therapy.
yeah.
She's like, do your therapy and do it religiously. You'll see it, it's coming out. And but that was the key. She had not used the muscles in her quadriceps and hamstring. They were not aligned for years. And
Yeah.
so the therapist got her back, and it is phenomenal to see her walk, straight and have a straight leg versus the other way she was walking before. So you'll love it. But that's a great story of combined therapists and combined surgery. It takes two, and that comes right out of her mouth. And
Well, and it takes a patient that has some grit because
yep,
she did the work there, right? She
yep,
came she came in and saw PT, a few times, a couple of times, 3 times a week, and for
yep,
an hour or so. But and then you did your work, but she had to grind most of that out. I love to work with patients that have that kind of determination and grit, and it's part of what we do. You and I and the healthcare team is to motivate these people to see, hey, this is what could be. It's worth it. It's
yeah.
worth the grit. It's worth the difficulty here. And so that's awesome. Yeah, I look forward to seeing
Thank
that.
you. Her name's Susan, so you'll see a video comes up. Susan, she signed all the video releases. We've done everything, but it'll be coming on our ASMC page. Probably under my name, but yeah,
Cool.
it's pretty awesome.
Awesome. So another question I have is like, what do you consistently find that PTs need to understand to do a good job with your patients?
That's a great question. I would say, most therapists over the years are very well trained and they know what to look for. A lot of times the doctors are also we all have different training and we
Hmm.
all have different expectations. Um, some people are alarmed about some stuff, some aren't about others. But I would say, if I was giving any advice, I would say the first thing is know your surgeon if it's possible. So if you know, hey, Dr. Sumko does a direct superior approach or a muscle sparing knee, these are the precautions, or these would be I don't have precautions, but if they're a posterior hip surgeon, maybe they have hip precautions. Know that if they're an anterior hip. So know the surgeon, but then also know the surgical approach. So when someone comes in, say, hey, what did you have done? And I know you guys do a good job at this. What did you have done? If you're able to see the incision, see it, also know what an infected incision looks like, or cellulitis, or, if it's draining, or those are the things that you'd want to notify the surgeon. Hey, we still got drainage at 5 days or 6 days. Like, is this, just want to make you aware, hey, there's a lot of redness and swelling that, is just spreading, or their pain is getting worse. They're going backwards. So knowing what a joint should function like, or what a replacement should function like, post-operative, 1 week, 2 week, 3 weeks, if they're 3 weeks and they only have 30 degrees of flexion, we're in trouble.
Yeah.
So know that stuff. For me, my patients, I like you to be at 95, at the 2 week mark, and
Yep.
and most of them come in at 95, their first post-op, and that's good. We don't want to see them going backwards. Um, knowing what function they should be at the right time frame, knowing what it should look like, knowing the surgeon if you can, and knowing the approaches he uses. And then the last thing I always say is asking them, what was your preoperative range of motion like before? Like
Yeah.
knowing what they came into the surgery as, because someone who only has a 0 to 30 degree pre-op motion, is hopefully they're at least 0 to 30 after surgery, if not more. But say they come into you and they're at 65 and you're like, oh, wow, you're way behind. And you just ask the question, they're like, hey, this is 30 degrees better than I ever had. It's
Yes.
going to be a struggle to get to 95, but you also know where they began. And I think that's important. And some people say, I've never bent my knee past 90. Well, you want to at least get to 90. And if
Yep.
you get more, that's gravy. Because it's been 30 years where their knee's been stuck at 90. So those capsules tight, and the back of the knee and the front of the knee, the ligaments are tight, tendons are tight. And so just knowing their function pre-op is the biggest thing I would say. Just if they're ever struggling, the very first question is, hey, what were you like before surgery? And they say, well, I could touch my butt, my heel to my butt. And now I'm only at 60 degrees and I'm getting a hard stop. Those are things to kind of start to set off some alarms, like, okay, you know, and then,
Yeah.
yeah, if their swelling looks appropriate and everything looks good, incision looks good, and they're still stuck, then yeah, then you say, I want to shoot a picture to my surgeon, hopefully, or their PA or whoever. Hopefully you guys are able to establish that relationship to be able to reach out and say, I just want to make him aware this is abnormal for him. So
That, that's excellent advice. Is there a fairly standard answer to how soon post-operatively we're going to see these people in the clinic?
that's good. So I usually tell my patients, I like 5 days. I tell them within 5 days, 4 or 5 days, get there. The first couple of days after any joint, the capsule, the swelling, it's going to swell and it's painful. Some therapy places maybe like to do just a first visit to establish care, learn about the patient, and get their goals or whatever, and that's fine. But I like that first 5 days. Really, what they're doing at home for me is icing, elevating, and gentle motion.
Yeah.
And so I usually tell them 4 or 5 days, the main inflammatory response has started to subside. And that's when I like them to see you. Some guys will like 2 weeks, up to 2 weeks. But I think you definitely don't want to go beyond 2 weeks before you guys are seeing them in the clinic, because, things, unless they're working really well or they have a really good pre-op education and been doing stuff at home, they'll come into you a little bit behind the 8 ball at 2 weeks. So you don't want that. But I say somewhere after, anywhere, some guys will like, 2 or 3 days after. I think that's fine too. I think it's just you got to make sure that swelling's down.
And hips, are you approaching those differently than you do knees, probably?
So hips, I still say 5 days just because it's easy for me to keep it all simple in a packet. Some hips don't even, their therapy is walking and getting around. I still like them to see a therapist because I still think you can do way more with a therapist than you can do on your own. So I still recommend my hips do it. But yeah, usually sometimes there's a little less swelling in the knee for sure. And, it's more of a ball and socket joint. So it's a little easier to rehab early on if there's inflammation versus a hinge joint that has rotation. So,
And why is it that we see more orthopedic surgeons not sending their PT, their hips to PT as frequently as they do their knees? Can you explain that?
yeah, I would say the only reason for that is, for some, and I do have some male patients that are like, hey, my activity level, I just want to walk without pain. And so they get their hip done and they're walking without pain, 2 days after, a day after, 2 or 3 days after, like, my activity level's low. I don't need to do anything more than walk. I'm just going to walk. And they do that. And that's good enough for them. The other reason maybe with hips, some hip surgeons may be worried about the hip stability, in the early post-op period of dislocation, and
That's
probably us as surgeons, we've probably all had that happen. Gosh, I gotta think about it. Maybe once I've only had it happen, and I think I was in residency where, and in residency, I wasn't doing a direct superior, I was doing posterior hip where
yeah.
they went to therapy and they were a little aggressive and the hip dislocated. And so they made these say, hey, I just don't want I want the capsule and everything to calm down and be stable and not risk that dislocation. But knock on wood, I don't think I've had any issue like that since being out in out of fellowship.
When I want my therapist that work at our company to have that answered by a orthopedic surgeon, because we hear a few things, and one of them is that the concern is that there's more worry that you're going to do harm with a hip in the way you just described, by not
Yeah.
allowing the stability to things to kind of stabilize. Another one is that this patient doesn't need it. As the orthopedic surgeon, it's sort of an accolade or a badge that they don't need the therapy. We hear that, which is sometimes the case. They don't. Um, Sometimes it's not, right? And anyways, but I think it's good for us to hear, hey, from the actual source, like what are those reasons? And we need to be really cautious. We don't need to be trying to get range of motion back at a hip, in that first week. Like, it's not necessary. We
Yeah.
need to be cautious
Soft
there.
tissues and yeah, it's the swelling and soft tissues. And that's what I love. That's why I say, hey, they're going to do stuff that you can't do at your house,
Yeah,
even if
yeah,
it's just getting those soft tissues back balanced, helping to get the swelling down, and keeping things moving. And so I think it's great. So I'm not a badge of courage guy, I think where my badge of courage is I do like my hips to, hip or knee, I just say, hey, you'll use the walker for a day or two and you'll ditch it.
yeah.
You know, that's my badge of courage where I feel like,
Awesome.
okay, hey, that's great. They're not working with assisted devices after day one or day two.
Yeah.
Um, but therapy, I think, is like I said, I give everyone a therapy script. I want them to go somewhere close to their house. I want it to be convenient so they don't feel like they're having to drive, 20 miles to go do it or whatever. I love to get them out and see a therapist because I know that they'll only be helped. I haven't, maybe one time in the valley, well, I'll say maybe twice in 11 years have I had a patient come back kind of unhappy with the therapy they got, or they felt like they pushed them too hard
Yeah.
but nothing that I can remember that was the true complication of someone, trying to get more motion out of anyone.
You know what I like to tell people, because you'll have people come in and they'll sometimes be like, I want you to push me, right?
Yeah,
And
yeah.
and those are the ones that actually you worry about. And then there's the ones that come in and they're really scared. Like, I've never been to therapy before. I hear it hurts a lot, that kind of thing. And you can just, then there's the whole gamut in between. I like to tell my people, I said, I really don't think I'm going to push you any more or less than you would want me to. What I'm trying to do is match where
Yeah,
you feel comfortable here. And yes, I can guide you because I've been through this so many times with so many others to kind of give you some guidelines, but you are very unique. Like you're not going to present exactly like anybody else in this room. You're not don't look at that
yeah,
person over there and said, "Hey, she had the same procedure I had on the same date." No, she
yeah,
didn't. I mean, even if it was
yep,
same Dr. Sumko on the same date,
yeah,
you guys are two different people. Your
yeah.
tissues are different. They're just not the same. We can
Yes, they're
figure it
never the
out,
same.
but just try to say, and your wiring, your nervous system is different. Like
Yep,
that that person or you might be able to take more pressure here and you might even want more. And we're going to take you to a place and then ask you where you're at on this. Like, how are you feeling? And you just have to listen to your people in therapy. Um, and there's a lot of them that don't want you to not push enough either, right? But the
yep,
guy who walks in and goes, "I'm going to be back to running a 10K, in the next 15 days," you go, "Oh my gosh, okay, hold on, man, we got to rein you in because you're going
yeah.
to do this thing." Like,
Yeah, and I do absolutely no, you're absolutely right. And that's perfect. Yeah. Listening to the patient, knowing that they come from different preoperative range of motions,
yeah,
different activity levels, different nervous stresses and pain, their pain system and pain scores and everything. Yeah, it's completely different. I always say, yeah, comparison's the great destroyer of joy. And
right.
when you start comparing yourself, you start to feel either one or two things happen. You either feel better about yourself, which isn't great, or you feel worse about yourself. So just don't compare yourself.
Well
So
said. Well
let's
said.
not let's not be the let's not be the high guy on the totem pole or the low guy. Let's be middle way.
No, I like that for sure. Well, this has been great. Again, I really appreciate your time, and this will help us as a company be better with as we work with so many of the people that have these joint replacement surgeries, and so thank you again. Really
Well,
appreciate it.
no, I appreciate it. Thanks for, yeah, it's been fun to chat and yeah, I do. I appreciate you bringing me on and I appreciate everything you do, Mark, and everyone at More Therapy. Like I said, I've never had anyone bad come back and I more often than not have people just super excited about how well they're doing in therapy. So to not only your company, all the therapists out there, I think it's awesome. So I appreciate it.
Well, thank you. Yeah, we appreciate you, and it's a great thing we get to do to help people out. So
Well,
thanks
thanks, Mark. I
again.
appreciate it. Yeah, I look forward to seeing you again.
Okay, have a nice afternoon.
Hey, you too. Take care. Bye.